Hi, everyone, and good evening. I'm Shelby Monier, Zero's Vice President of Patient Programs and Education, and I really hope you've enjoyed all of today's amazing sessions. I'm so excited for our next presentation. I'm here with Dr. Rachel Rubin, a board-certified urologist. Hey, Dr. Rubin, a sexual medicine specialist and an assistant clinical professor at the Department of Urology at Georgetown University. So together, we're going to dive into prostate cancer and sexual health and well-being. And as we know, prostate cancer patients, their partners, they're not only up against this cancer that they have to battle, but also battling these extremely common side effects and like erectile dysfunction, general difficulty in maintaining a healthy and fulfilling sex life after a diagnosis. So we're so excited to have this on really our first night of educational programming. We know that you probably have a lot of questions. We're excited to take those at the end. So with that, I'm going to hand it over to you, Dr. Rubin, to take it away with us.
Shelby, thank you so much. It is so wonderful to be here. Dangerous that we're doing it live, so hopefully no technical difficulties. I am no Cal Ripken, I promise you that, but I will do my best to make this fun and lighthearted and really try to do my best to tell you you're not alone. Not just prostate cancer survivors have sexual problems. 50% of 50-year-olds have erectile dysfunction, 60% of 60-year-olds, 70% of 70-year-olds. And so sexual problems are one of the most common things that we see. What's cool about my practice in Washington, D.C. is I take care of couples. I take care of anyone who comes in the door. And so sexual health is often a challenge for multiple genders. And so if there are issues, I really try to get everyone to understand those issues and understand the biology behind them. So I'm going to share my screen with everybody and hopefully we can make sure everything goes well. Let's try this. Shelby, give me a thumbs up if you can see my screen. Shelby gives me a thumbs up. All right, so I am a urologist. I did a fellowship in something called sexual medicine, where I learned how to take care of all genders for all kinds of sexual problems. I see a lot of prostate cancer survivors. I love working with cancer patients because I need, if we're going to keep you alive with all these treatments, well, how the heck do we get you to keep living, keep appreciating life, keep the things that are fun about life? How do I improve your quality of life any way that I can? Please, I know you're all from all over the country, maybe all over the world. Please find me on social media. I can get a little bit loud on Twitter, but definitely reach out to me in any way possible. I will give you my disclosures tonight. I truly believe that sex can look different ways and should refer to more than just a penis going in a vagina. I think that lots of people have great sex without erections, and I think successful sex does not always have to equal penetration. And I also think that the word foreplay should be removed from our vocabulary because it is not helpful to anybody. With those disclosures in mind, you have to joke in this world. If you can't be funny, there is no reason to live. And so I hate this slide, right? Because we think men, you guys are so easy. You're just an on-off switch, and women are so complicated. They've got all these buttons and bells and whistles, and we can't possibly figure out what's going on with our female patients. And it's just not true. I promise you, I see patients of all genders, and we're all equally as both complicated and not complicated. And we also have to understand how our bodies work. It's really scary if you're injecting something into your body to give you an erection. Your spouse, your partner can be super terrified, whether you have a partner or not. When you understand what's happening in your body, then you can have the control to understand how to fix it or how to make it better. So my goals today are really, how do we improve your quality of life? How do I teach you something about sex ed? Because sex education is not very good in our country, no matter where you live. And what are the different treatment options when you are diagnosed with prostate cancer? What are the different things that you can use in your toolbox to help you? There are many things that can go wrong when men have issues with sexual function. You can have low desire or hypoactive sexual desire disorder. There can be erectile dysfunction. We can have issues with ejaculatory dysfunction. Either you orgasm too quickly or not quickly enough. You can have problems having an orgasm altogether. And we also certainly see a lot of sexual pain disorders, especially after treatments like a prostatectomy or radiation therapy. But we also know that people are having sex no matter how old and how frail and how sick that they are. That when you ask men and women of all ages if their sexual activity is important to them and if they're trying to have it, even people who are in poor health, up to their 80s, 90s, people are still interested in maintaining some amount of sexual health and some kind of sex life. So don't be afraid that you're still interested. You should be. And this is new data that I've recently looked into, this idea that partnered humans live longer. If you are in a partnered, committed relationship and you're happy, you're going to live longer than someone who is divorced, never married, or widowed. Why is that? Well, we also see divorced and single men experience poorer health outcomes. There is a study that you can take into all the things into consideration: cardiovascular, age, body fat, smoking, blood pressure, diabetes, cholesterol. And partnered people have a 46% lower rate of death than their unmarried counterparts. We know in prostate cancer that when it's been studied over a 17-year period, that often married men actually survive longer than both separated and widowed men. And there's improvements in cognitive function, reduces in Alzheimer's disease, improvements in blood sugar, and better outcomes for hospitalized patients. So why am I telling you all this? How can we prevent loneliness, increase our patients' partnerability, promote healthy partnerships? And when do these relationships fall apart? And how do we set expectations and advocate for all members of the couple? I know this is a prostate cancer support group, but we're also going to have to talk about all members of the partner. Divorce often happens between the 40s and the 60s. Okay, there's something very specific that happens when people are between 40 and 60 years old. Women are going through menopause. And so it's really important when you're dealing with your prostate cancer diagnosis, if you have a female partner, then it's important to understand what is happening to your female partner at the time of your diagnosis. Because while you're going through your treatments and going through your chemotherapy or your radiation or your prostate surgery, female partners are becoming castrate. Essentially, female partners are on androgen deprivation therapy, which we know can cause low libido, arousal issues, depression, bone loss, all sorts of hot flashes and night sweats. And so we know early in menopause, many women have sexual problems, but as menopause continues, it's the norm. Okay. And when you ask doctors, we have so many doctors who are good at treating men's health, prostate cancer. But when you ask doctors, well, how good are you at treating menopause symptoms? Less than 7% say that they feel that they have a medical background feeling like it's adequate to treat women in menopause. So you're at a time when you need the most support with your prostate cancer diagnosis. But again, if you have a female partner, then they are probably going through just as much of a difficulty, and no one is hearing them or really trying to help them. I spend a lot of time in my work talking about biology and just the basics of sex ed, because I don't know about you, but this is how I learned sex ed. I had a middle school gym teacher who said some words to us, scared us a little bit, but didn't really explain how it all works. And so when are we supposed to learn? What is the point where we're supposed to feel comfortable that we know what's going on? And so when I see someone in my clinic who's had prostate cancer or whatever their problem that comes in the door, whether it's erectile dysfunction or pelvic pain, I break it down in my head. What's going on in their brain? What's going on in their relationships with their culture, where they come from, how they think about sex? What is their partner situation? What are their hopes? What are their goals? I have to think about what's going on in their spinal cord, because the spinal cord is the interpreter of connecting your brain to your genitals. And if that's messed up, if people have low back pain or disc issues, that can affect their sexual function. And I also have to think of everything that's going on in your pelvis, in your genital region, which is made up of muscles and nerves and bones and blood flow, and all sorts of problems can occur regardless of prostate cancer diagnosis. And so it's important to understand each of these aspects, and even more of, you may have to see more than just a urologist. Now, I'm a urologist, but I can't do my job alone. I work extremely closely in what we call a multidisciplinary way. I have to work with mental health providers. I have to work with pelvic floor physical therapists. Maybe I work with urologic oncologists. Sometimes I work with spine doctors. I will work with whoever I need to maximize your sexual health benefits. And it's important, if you look at this picture, this is a side picture of, if you look here, right, this is the prostate, right? The nerves come out of your spinal cord and then the nerves go over and they innervate your bladder, your bowels, they innervate your prostate, and these are your erection nerves, right? These are the nerves that help with erection. So maybe if you have a colorectal cancer, that can affect your erections. If they remove your prostate, that can affect your erections. If they radiate your prostate, that can hurt the nerves to your erections. And you may also have bladder problems. You may have leakage. You may have fecal incontinence or rectal bleeding. And it's all because of what can happen. All of these areas happen very close together. Now, we often talk about nerve sparing surgery, which is a little bit of a misnomer because we all think as patients, well, there's a nerve, they're going to see it and they're going to spare it. But it's not so simple. There is no one nerve that the surgeon sees. There is a web of tissue that the surgeon hopes that there are nerves that he is protecting, but it's almost impossible to predict who's going to come out of their surgery with good erections and who's going to come out of surgery with poor erections. And that is extremely frustrating, especially as many people going through prostate cancer surgeries already have underlying issues that can affect their erections. And how about orgasm? So if you take your finger and put it behind your scrotum, in that perineum area, there is a big muscle there called the bulbospongiosus muscle. It is that muscle that is responsible for your orgasm. It is this muscle responsible, for ejaculate coming out if you still make it. And so many things can harm this muscle or harm this tissue. I don't know about any of you Peloton riders going on, but I'm seeing a lot of pelvic pain and erectile dysfunction from your constant bike riding. We also know that radiation can affect muscles and tissue health, and these muscles can get weak over time as you age. We all start the same way. Everyone starts as this person here, and you develop either a penis or a vulva depending on your chromosomes and your hormones. And so it's important to understand that hormones are very important for this tissue development. In fact, we know that androgen deprivation therapy, if you are on Lupron or one of the other medications that cause you to lose testosterone in your body, it feels awful for every part of you, especially your sexual health functioning, right? You get low libido and fatigue and erectile dysfunction, hot flashes, osteoporosis. You can have heart issues and weight changes and worsening of diabetes. And it's no fun to be on androgen deprivation therapy, but it's important for you to know that every woman over the age of 50 is on androgen deprivation therapy. Menopause is not just hot flashes and night sweats, but every woman over the age of 50 is essentially on androgen deprivation therapy. She gets hot flashes and night sweats, but she gets osteoporosis and fractures, urinary tract infections, backaches, joint issues, heart problems, thinning of hair. All of these things happen with menopause, and some go away, but many get worse and worse and worse over time. And it's important that we understand that hormones play a very important role in your desire, your interest, as well as your arousal, your erectile function, or in female arousal as well. And so if you are a man with no hormones in your body from prostate cancer, you would probably expect to have problems with your interest levels, your desire, and problems with your erections. Many men are on testosterone therapy, even with a history of prostate cancer, to improve some of these issues that can happen. But often, not a lot of doctors, remember I said less than 7% of doctors feel comfortable treating women in menopause. And so there's not always an equal partner to have that desire or that arousal, because many women in menopause are completely castrate. They have no hormones in their body. And so they have low desire and problems with intimacy and arousal. And many patients are put on antidepressants, which we all know, serotonin here, very negative to all of these things as well. And there's a lot of sexual side effects with a different antidepressant. So it's sort of a recipe for disaster. When couples are in their 60s, someone gets a diagnosis of prostate cancer, the male partner is going through a lot of changes and a lot of stress. And then if he has a female partner, she's going through a lot of changes. And then 2 years go by, they ignore the intimacy, then they come back together and they realize things are just not working how they used to. She has pain with intercourse. He has erectile problems. So honey, let's just forget about it. Let's do nothing. Let's ignore this topic altogether because nobody's good at talking about sex. And so then they just move on with that and forget about the intimate part of their lives. And that's a problem, right? Because intimacy was important to you at one point, and intimacy is about so much more than it having to look a certain way that it did before. So again, when it comes to biology, I really want you to understand that we are all actually a lot more similar than we are different. Remember, I said we all come from the same part. You either grow a penis or you grow a vulva. And so these, as a urologist, I spend a lot of time thinking, well, what do I know about the male anatomy and how does it affect my patients who have the female anatomy and vice versa? And so we know that most humans with clitorises do not experience their sexual pleasure from penetration. In fact, 82% of women do not orgasm from penetration. Let me explain why. It's biology, right? Go back to biology. So the penis and the clitoris are exactly the same thing. They are made up of the same muscle tissue, okay? Muscle. The penis is just a muscle. The clitoris is just a muscle. The clitoris is a big organ that goes all the way down to the butt bones, just like the penis actually goes all the way down to the butt bones and is made up of erectile tissue. The clitoris is nowhere near the vagina. So if this is where you're penetrating, you're nowhere near the part of the body that becomes erect and allows for orgasm. So I like to tell my male patients, if you rub your leg furiously for 5 minutes, do you think you'll have an orgasm? No, you're not going to have an orgasm because your leg is nowhere near the penis, which is why 82% of women do not orgasm from penetration, but rather require some clitoral stimulation or a vibration, in fact, because the majority of the clitoris is internal. I tell my male patients, if your penis was completely buried inside of you, how would you have an orgasm? It would be very difficult. And so understanding the biology can be very helpful in saying, okay, honey, maybe sex doesn't look exactly how it looked before. How can we still have fun? How can we still enjoy each other? How can we still show intimacy to each other? And again, going back to biology, when you understand how your penis works, then you understand what treatments you may have had for prostate cancer and why it maybe doesn't work as well anymore. And most importantly, what do we do about it to get it working better? So it's pretty simple, actually. And I love anyone who's heard me speak before, and hopefully nobody has to hear me twice. But if you have heard me speak before, I'm sure you have seen this picture. This is a tiger, right? Do you want to have an erection if this tiger is chasing you? I'm hoping somebody's smiling and laughing because I'm speaking to nobody here. You do not want to have an erection if a tiger is chasing you. You will lose the erection or you will get eaten by the tiger. Either one comes first. And so it's really important that you understand, if you are running from a tiger, that's adrenaline. That is a biological chemical that is going through your veins and causes you to lose an erection. Erections are just muscle. It only works when that muscle is relaxed. Think of a sponge. If that sponge is filling with water, it expands, it gets bigger, 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 right? But if you squeeze out the sponge, you lose all the water and it shrivels up again. So you always have to understand, well, what's going on with the tiger in my brain? If I'm stressed, if I take that Viagra and I'm saying, honey, I want to do this. Is it going to work tonight? Is it not going to work tonight? I just don't know. It's not going to work, right? You've already got that tiger in your brain, and sex is going to be much more difficult and you're going to be less present. This is why masturbation for many is so wonderful, because you're alone with your thoughts, you're alone with your own feelings, and you don't have to talk to anyone. You don't have to interact with anybody. And that's where partners get often in trouble, because they have their orgasms on their own, and then they avoid any kind of coupled intimacy because it's a lot of stress on the body to have to really talk about these issues. Nobody taught us in middle school how to say, honey, that move you've been doing for 30 years, it's just not working anymore, right? It's not easy to say. But we know erectile dysfunction is almost never all in your head, right? It is almost always a biological cause. So even if you had prostate cancer, many of you had underlying diabetes or high blood pressure, or were on medications that can cause sexual problems, or had low testosterone. And then you add a surgery or radiation, and that compounds on the difficulty in making that penis muscle work better. It's really important that you understand, if you had erectile dysfunction before your prostate issues, it is often a marker for cardiovascular problems. Why? Because of clogged pipes, right? So if your penis doesn't work, it could be a sign that you may have heart issues down the road. And that's really important. What clogs first, your small pipes or your big pipes? Nobody's answering because I can't talk to anybody right now. I'm all on my own, but your small pipes are going to clog first, right? Your penis, the arteries in the penis are 1 millimeter. They're tiny. The arteries to your heart when you have a heart attack are 3 millimeters. They're much larger. So erectile dysfunction actually happens long before you have a heart attack. And so it's a wake-up call for me to say, hey, everybody, eat right, exercise, take good care. What your primary care doctors are telling you is good for your heart. Don't smoke, take care of your body. Don't have extra weight. All of that is good for your penis as well. We know many medical conditions, as I said, coexist with erectile problems. Diabetes, listen, they check the bottoms of your feet for nerve issues. The nerves to your penis are also very small. So the worse your diabetes, the worse your erections are going to be. Your penis is just a marker for your overall health. And so all of these issues can change the health of the erection. We know many medications can affect the health of your erections. That doesn't mean stop your medications. Again, knowledge is power. Sometimes we add, sometimes we subtract, sometimes we adjust. Work with your medical provider to figure out how to adequately optimize your sexual health, because you can tell, hey doc, I know I need to be on blood pressure medications, but maybe there's one that's not so harsh on my erections, or maybe there's an antidepressant that has not as many sexual side effects. Can we work on this? And that's really important. Again, when the muscle, this is what the cross section of the penis looks like. It's just muscle. When it is not filled with blood, it looks this way. And then when it engorges and fills with blood, it looks this way. So if you have high blood pressure or clogs in your pipes, think of a faucet just going drip, drip, drip. It's going to take a long time to fill the sink. But if you put a fire hose in there, the sink's going to fill up right away. So what happens when you have a prostate removal? Well, the nerves can be severed, which means your brain and your penis are not connecting with that pipeline of nerves that I talked about. Or you can also get damage to the tissue itself. You can have issues with muscle damage from low testosterone, from androgen deprivation therapy. We know radiation can cause damage to tissues. But it's really important to know there is so much that we have in our toolbox to help men improve their sexual health and their sexual function. It is all about shared decision making. I need to get to know my patient. That's why I spend a lot of time with my patients. You get an hour at our first visit. I have to know everything about you and where you want to go and what your goals are. And once we figure that out, then we put our heads together and come up with a treatment plan. Is it pills? Is it a vacuum pump? Is it a suppository? Is it an injection? Or is it a penile prosthesis surgery? All treatments, the best treatment of all is the one that you will actually do and have fun using and have fun experiencing, because sex is supposed to be fun and enjoyable. And if it's not, if it's giving you stress or anxiety or frustration, you're not doing it right. Nobody's watching you. Nobody's posting this, on Twitter or anything like that. This is about you, your own sexual health by yourself or with a partner, and nobody else is involved with it. So it has to be right for you or you and your partner. If you smoke, please quit smoking. I can't tell you how good it is for your penis. Forget about the heart issues and the cancer issues and all of that. For the love of your penis working, please quit smoking. It is so important. Exercise is excellent, right? It's good for your heart. As I said, the endorphins, the physical activity, losing weight, all of that is really good for your penis. There is good data that the Mediterranean diet is probably good for erectile function. So I encourage everyone to eat healthy. And I think there are sessions on that during this wonderful conference that you're at. Behavioral health. This is biopsychosocial. This is everything, right? Remember, multidisciplinary. If you've got a tiger in your brain, if you're frustrated, if you're angry, if every time you try to have intimacy with your partner, you're thinking about a prostate cancer diagnosis, or you're in your own head, or you're frustrated, or you have trauma history or abuse history or anything horrible happening, gosh, it's a pandemic. There's not a human on earth who doesn't need therapy, right? And so there are wonderful behavioral health specialists out there. There is a wonderful website called Psychology Today. Just go to psychologytoday.com. You put in your zip code, you can put in your insurance, and you can find a therapist, whether it's for a cancer diagnosis or anxiety. You can even search sex therapy specifically and work with somebody in your area who has an interest in sexual health. ASECT, is a specific sex therapy organization where you can find a sex therapist in your area. And who doesn't need a sex therapist, right? I always joke, no, everyone could benefit from sex therapy. Nobody is so good at sex that they can't get better, because it's all about communication, right? If you can get better at communicating with your partner what each of you want, if you can explore those things, and if you can say, hey, our bodies have changed, we're aging, there are all these issues, does that mean we have to completely stop all intimacy? No, that would be a shame. That would be horrible if you just forget that part of your life exists and is important to you. How about these? Everyone knows what these are, right? The little blue pill, this magic blue pill. So this is Viagra, which, as we all know, came out about 20 years ago and changed the market completely. What is Viagra? Remember, I said the penis is just a muscle. All Viagra is a muscle relaxer. That's it. It just relaxes the muscle of the penis, and like a sponge, then it gets bigger, bigger, bigger. Now there's 4 different types. There's Viagra, there's Cialis, there's Levitra, and there's Stendra. Different ones work for different people. Some work for everybody, some work for nobody. And it's a muscle relaxer for everywhere in your body. So what else can happen? Man, you can get facial flushing, you can get headaches, you can get indigestion, muscle aches, a runny nose, a stuffy nose. I hear it all. Why? Because it's relaxing muscles in other parts of your body. And so when you understand it's a muscle relaxer, well, then you can say, honey, I'm taking my muscle relaxer tonight, right? Think back to this picture here. Oh my gosh, it's just Viagra. What are you doing to yourself? Honey, I'm just taking my muscle relaxer, right? I'm taking that pill that helps the muscle to relax. If you're taking Viagra, you want to take it an hour before, typically an empty stomach. Alcohol makes it not work as well, so you want to be mindful of that. Cialis tends to last a little bit longer, meaning you can take it on a Friday and still expect it in your system Saturday night. Stendra starts a little bit quicker, so you don't usually have to take it an hour before. You can take it a little bit more quickly. And really important, this has changed my practice fundamentally, is Cialis and Viagra are generic now. It is dirt cheap to get the cash price of Viagra and Cialis. So if you've never heard of this website called GoodRx, this is where you can search for all of your medications and get the cash price available. So you get your doctor to write a prescription for Viagra or sildenafil, which is the generic name, and you go to GoodRx and you print out a coupon and you say, pharmacist, I want the cash price. Here's my coupon. And you're talking, 30 pills for like $20. I'm kidding, not kidding you. And this is just for Viagra and Cialis, which are the 2 that have gone generic. And so you don't have to ration them anymore like the old days when it was so expensive. And now it is not expensive anymore. If pills don't work, or maybe if pills only work part of the way, then what about a vacuum erection device? This is a wonderful product that is actually underused. And I think it's underused because many people will get it, they try it once and they say, I don't want it, not for me. This is a device that takes a little MacGyvering, if anyone remembers that show. You got to tinker with it a little and you got to make it work right for you. And so maybe a pill gets you 50% of the way there or 60% of the way there. Could you then put your vacuum pump on, get a larger erection, and then use this constriction band that goes around the base of the penis to hold the erection in place. It has been studied. It's been around for a long time. It's very safe. I also find this is a helpful device when you want to stretch your tissue and expand your tissue, prior to a penile implant surgery. And there's all sorts of, it's sort of like exercise for your penis. So you brush your teeth and you comb your hair, you put your penis pump on for a few minutes, and you can help to maintain the length and the girth that you are used to. I find this, for anyone interested, take a screenshot of this with your phone. This is a very good YouTube channel of a woman who talks all about vacuum pumps. She's got a wonderful Australian accent, and she really does a nice job talking about prostate cancer recovery and how to effectively use your vacuum pump. So this is something to consider. Now, remember, I said clitoris is like vibrators. 82% of women do not orgasm with penetration, right? 82%, that means almost all women don't orgasm from penetration. So, and most of their clitoris is internal. So this is why more than 50% of women use vibrators. It's not because their partners are not wonderful. It is because anatomically their clitoris is buried underneath the skin. And so remember, I said penises and clitorises are the exact same thing. It is the same anatomy. It is the same under a microscope. And so penises also respond really really well to vibration. I truly believe that we need to expand our use of things that vibrate in the bedroom, because pleasure is pleasure is pleasure. And whatever tools we can add to increase your pleasure is really useful. So there are wonderful devices out there that are very high end, made of really nice materials, and that can be really used for couples or solo in order to improve orgasm. I think this is great for diabetic patients who lose some feeling, patients with back problems who don't have as much feeling or have what we call delayed orgasm, and it takes forever to have orgasm. Maybe it takes 25 minutes and your partner starts having pain after 5 minutes. What do we do? You know, these are ways to speed up the process or to enhance a sexual pleasure. So there's all sorts of wonderful sex tech, as we call it, sexual technology out there. Your doctor may have prescribed you something called Muse. Muse is a little pellet suppository that goes into your penis. I use this a lot with my veteran patients at the VA hospital. It's an intraurethral suppository that acts as a local muscle relaxer. So think, instead of Viagra by mouth, it's Viagra directly into your penis. It works very, very well. It can occasionally cause some discomfort and some burning sensation, but it is, if you can get it, it does work quite nicely. And what about injections, right? So if you haven't tried this yet and you're struggling with erectile problems, injections are a wonderful thing to try. It takes getting your head around of, what, crazy lady, you want me to stick what, where? You got to be kidding me. Well, it's a teeny tiny needle, okay? And you put 3 very strong muscle relaxers directly into the penis itself, and it works extremely well for those with erectile dysfunction. Listen, we all see, anyone who's watched a pornography video and sees someone with an erection for 2 hours, it's all fake. The average erection, the average person only lasts for about 5.5 minutes. How are they lasting for 2 hours on these crazy movies that people are watching? The answer is, just like the WWE and wrestling, it is all fake. And they are often using these types of injections or all these different products. So these are things that have been extremely helpful for my patients in order to get them their own natural erection on demand whenever they want. And it doesn't have the same side effects as you get with some of the pills or other therapies. And then some of you may have one of these. Some of you may want one of these. This is a penile implant. So we can put a inflatable device into the penis that gives you an on-demand rigid erection whenever you would like it. Now, it's a mechanical device, and so many people wait until other things have failed. But I certainly have patients who come in and say, you know, I just don't want to do injections, or I just can't do anything else. I want a reliable erection. Now, there are some downsides to the implant. It's like a new knee or a new hip. If it gets infected, it has to come out. The infection rates are about 1%. It may break after 10 years, and then you may need it replaced. It doesn't replace your own natural erection, so it's not, you don't feel the engorgement that you once felt, and it certainly won't make you longer or more girthy, but it does get you functioning and pretty reliably functioning at that. And it's really a wonderful surgery that many people in your area, I'm sure, do. And there's a wonderful network of doctors who we do these types of surgeries. Now, what's the research? I'm sure somebody's going to ask me a question about all the excitement, all the snake oil ads you hear on the radio about shockwave therapy. Dr. Rubin, someone promised me a P shot. Someone promised me a stem cell treatment. Someone promised me shockwave. And my answer to you there is so much excitement going on right now, but we're not in prime time. And so if you find that someone is offering shockwave therapy, you want to make sure it's within someone who really understands the research, who understands the data, and who's using, really doing it for experimental purposes. The idea of, if your penis is damaged, can we use a shock wave to heal the tissue and to make it, to bring more blood flow, to bring healthier tissue? There's all sorts of different technology out there, some good, some less researched. So just be careful. If someone's asking you to spend a ton of money on something, make sure you trust that person and you trust that they have your best intentions in mind. Now, we see all sorts, this is just erectile dysfunction. We see all sorts of things from prostate cancer patients, and all men, whether it's low testosterone, penile curvature, orgasm issues, or urinary incontinence. And so we'll talk about those a little bit. So post-prostatectomy incontinence. Many men will leak after a prostate treatment. Some will leak just with orgasm. Some will leak when they cough, laugh, or sneeze. And remember, I said there's this muscle here that lives underneath behind your scrotum that is responsible for your orgasm. These muscles also, when they teach you about Kegel exercises, these are the muscles that they have you strengthen. Just like if you get a new knee or you have a hip surgery, you get a physical therapist. Everybody who's been to a prostate cancer therapy should go to a physical therapist if you have one in your area. It will change your life. Pelvic floor physical therapy is one of the absolute best things you can do for your urinary and sexual health. It can strengthen your muscles. It can help with any pelvic pain, and it certainly can help with leakage as well from any treatments. This is the way to find a physical therapist in your area. The APTA, the American Physical Therapy Association. Please, these are brilliant humans, and there aren't enough of them, and there aren't enough of them who deal with male patients. But this is something both male and female patients of mine get so much benefit from, and these are my equal partners in treating people with sexual problems. We have a book recently published. This is by the Massachusetts General Hospital about pelvic pain, and there are chapters. I helped to write the chapter on sexual health as well as urological problems causing pelvic pain, and it's a really nice resource for patients and their families, because pelvic pain, whether it's on the female side or the male side, which I treat a lot of, is really just a devastating condition. If the leakage is so severe, there are surgical treatment options for the leakage. This is called a sling to help basically provide a stop for the flow of urine. So when you cough, laugh, or sneeze, that you don't leak. It can be a really great option for someone who has mild urinary incontinence. Now, if you're leaking pad after pad after pad and going through so many diapers, often a urinary sphincter is a better option for you, as it can be more tight around the urethra. And again, these mechanical devices are not without risk, but they can be life-changing to improve the quality of life, because if you leak all the time, it is so difficult to do. Almost leaking patients are just unhappy patients, and anything we can do to help with leakage is really, really important. Certainly, we see a lot of men with penile curvature, Peyronie's disease, and there are all sorts of treatment options available. One really a new device that has been really helpful to patients at home is a new traction device available called a RestorX. It certainly can help a lot of people while they may not want to go into the doctor for surgery or for injections to straighten their curvature out. These are things you can do at home to try to straighten things out. So there is so much we can do for all of our patients, whether male or female. If you're having pain with intercourse on the female side, there's so much we can do to help. And most importantly, it's important we know that our partners are having these issues. The most rewarding thing that I treat on the female side is what's called genitourinary syndrome of menopause. So without hormones, the vulva and the vagina get dry, and it has decreased lubrication and painful sex and decreased arousal, orgasm, desire, irritation, burning, and itching. Gosh, it's not even just about sex. These women will have urinary frequency or urgency and even recurrent urinary tract infection because their body loses the acidity to fight infection. This is so easily treated with local vaginal hormone therapy that is safe, that is not risky. Even if you have a cancer diagnosis, it is one of the safest, most wonderful treatments you can do. And that will allow a female partner to engage in sexual activity if it's become more and more difficult over time. So that was a long-winded, a lot of information for everybody. If you like what you heard, you can, gosh, I'm sure you don't want to listen to any more, but Zero did a podcast with me where I talked probably all the same things that we talked about in this podcast. Please feel free to reach out to me on social media, or I'm happy to give out my email and get in contact with anyone if they do have questions. So why don't we bring Shelby back here, and I want people to ask questions. Hopefully I wasn't just talking to nobody and there were people around. What are we getting any questions?
Yes. Okay. Do you need to take a breath? That was amazing.
You know, I had water.
Okay, you grab water. I'll grab a question.
We're good. I'll keep going. We'll stay all night.
Excellent. Yeah, we do have a couple of questions. So you talked a lot about hormone therapy, but I would say at Zero, the questions that we get probably come the most from men who are undergoing some form of hormone therapy. Could you spend just a few minutes diving into that? What do you see specifically, maybe the most often in your practice?
I think just the key with if you're on hormone therapy or what we call androgen deprivation therapy, if we remove all the testosterone in your body, the reason you get the most questions because it hurts the most, right? It is so life-changing to undergo hormone deprivation therapy. Not having testosterone in your body affects your libido, your erections. Remember, testosterone, think Arnold Schwarzenegger, testosterone is good for muscles. So anywhere where muscles are important, you're gonna have issues. And so in these using these life-saving therapies, they can be life-altering therapies as well. And so part of it is understanding it, being prepared for it, having a team around you to support you when it comes to the different side effects that can occur with hormone deprivation therapy or androgen deprivation therapy. And so part of it is knowing, okay, I am not going to have my highest libido. My erections aren't going to be so wonderful. So what are ways that we can support each other? What are ways that we can, be intimate, even maybe if I'm not so interested all the time? And I think also an understanding of that this is what every woman over the age of 50 is experiencing. And men don't understand that all the time. And for you to say how in distress your patients on androgen deprivation therapy makes you realize how many women are suffering and nobody's paying attention to that, right? We just tell women to suck it up. This is called aging and live 50 years of your life, with no hormones in your body. And so that's a big problem. And so my hope is that as we develop prostate cancer treatments, we don't have as many things that affect hormones and don't both for breast cancer patients as well as prostate cancer patients, because the side effects are enormous and it's really frustrating. That being said, if the alternative is not living, we got to keep you living, right? And so if we're going to keep you living, we have to find ways to keep life in you. Does that make sense?
Yeah, absolutely. So we have a question about insurance coverage. Have you heard, and can you speak to insurance covering penile implants?
Yes, it's a great question, and an important one for advocacy. And so it's very variable. Medicare does cover penile implant surgery. At one point, it was on the chopping block. Medicare used to cover vacuum erection devices, and they cut it a couple years ago, and that's a huge problem. And so really, you got to write to, people don't picket outside of Congress about their vaginal estrogen or their erection drugs, and it's kind of a problem because the penile implant was almost not going to be covered. And there is a rumor going around that a congressman or a senator had a penile implant and really stepped in at the last few moments to advocate for keeping it on Medicare coverage. Now, with commercial insurances, it's very variable in terms of the coverage. And I have heard from my colleagues, we've been very successful in the DC area, but certainly we do hear from our colleagues that there are some insurance companies that don't consider it an important procedure. And that is not fair, because this is, I very much support patients being able to have a quality of life, especially after a prostate cancer procedure or treatment.
Well, and Zero's summit is part education, part advocacy, and our advocates are here and they're listening, and our Vice President of Government Relations and Advocacy is also listening. So maybe that's a new advocacy ask for the Zero team in the very near future. I love that. Excellent. Well, we do have another question. This one is, this came through on our app. So thanks for listening. Those of you who are listening through the app, if nerve sparing radical prostatectomy is done, when are you recommending that the ED drugs be started? This person asks if it's preferred that you start 2 weeks prior to surgery and then continue.
It's a great question, and data around penile rehab is all over the place. And my answer is use it regularly and stretch it often. And so I love the idea, because I have patients who don't touch it for 2 years and then all of a sudden try to have erections and everything is tight and painful and difficult. And also the emotional stress of I haven't had an erection in 2 years comes with a lot of mental health issues around it. And so I'm a big believer in stretching things early, getting the tissue to expand, think of it as like the tissue expander, getting the tissue moving. I believe God gave you nighttime erections so that even if you weren't masturbating or using it or having sex, that your penis was getting blood flow through it and things were moving through it. And so I think there's no magic, and then the research is actually all over the place. There's no perfect regimen, and so don't beat yourself up about it. But I love the idea of getting people on the PDE5 medications, the Viagra, the Cialis, which remember, they're super inexpensive, the cash price, getting on them early and then doing challenges, whether it's using your vacuum pump regularly or learning injections early as a way to expand and stretch and get the tissue working. It doesn't have to go anywhere. It doesn't have to equal penetration. It doesn't have to equal partnered use, but sort of getting that the tissue moving. But in terms of fixing the problem, there is not very good data behind that. The best way to know if your tissue is going to heal is really time. Usually in about 1 to 2 years, you really know where things are going to lie, but don't wait for your own tissue to be the only thing that works. Add things to your toolbox. Maybe one night's a Viagra night. Maybe another night is a vacuum night. Maybe another night is a no erection device night where you use vibration. And so you have tools in your toolbox to have different experiences, if that makes sense.
Yeah, absolutely. The more tools, the better. Is a prescription needed for a vacuum pump?
Nope, no prescription needed for a vacuum pump. And there are all sorts of, I would get a medical grade one. There are all sorts of options out there. There are manual pumps. There are ones that are battery powered. Stick to some of the more reputable brands. With a quick Google search, you can find kind of the more reputable brands. Usually they run around the $200 range.
Okay. Yep. Great. Thanks for hitting on that. That was a follow-up question with some recommendations or an ask for a recommendation. And then I guess a second follow-up, how often can you use the vacuum pump? Is daily too much? And then also to that end, how long can you leave the band on once you take the vacuum pump off?
It's a great question. You really don't want to leave the band on for more than 30 minutes if it's becoming painful, or definitely don't fall asleep with the band on. That's a big no-no. So you got to be careful of that. So band, keep it on for as long as about 30 minutes, we like to say. In terms of the vacuum stretching, you certainly can do it daily. You can kind of pump it up, leave it up there for a few moments or a few minutes to stretch the tissue, and then let that vacuum go. You don't necessarily need to use the constriction band each time, but just using it as a stretching therapy. And you can do that every day. You're not going to harm anything. Don't spend all your time in the bathroom totally focused on the vacuum pump, because you're going to miss fun life on the outside as well. There's a lot of very good Netflix out there these days. And so don't consume yourself with only using your vacuum pump.
Right. And a couple of questions regarding how long men can use Viagra and Cialis, and also about the dose. Is a lower dose better, and how long is it recommended to use that, or how often, I should say?
Yeah, well, we only have data from using a Viagra since 1997, but it's a very good data, and we haven't seen long-term issues or problems. We really don't. When guys talk about it's not working as well anymore, sometimes that is as guys age, their tissue gets less healthy. And so sometimes it doesn't work as well because diabetes has gotten worse or blood pressure issues have gotten worse. And so sometimes if Viagra works for you and then stops, trying a Cialis or one of the other ones can be helpful. In terms of doses, if you have a severe disease or bad erections, you do want to stick to the normal doses, the 100 milligrams of Viagra, which is the same as sort of the 20 milligrams of Cialis. If you have mild issues, then you can go lower with your doses. So I certainly have a lot of young patients who take a very low dose of Cialis every day, even to keep kind of a 5 milligram dose, just to keep a a low level together. I love that dose for penile rehab, right? Take a 5 milligram every day of Cialis, and then a 20 milligram of Cialis before you want to have an erection and engage in partnered activity or solo activity for that matter. And so anytime you go above the recommended doses, you are going to have a significant increase in side effects. You're going to have more of a headache, more of a runny nose. And so I don't recommend going above the recommended doses. If the pills are not working for you, I recommend quickly getting things like injections involved, because then you can have a reliable erection without sort of the fear of that headache or that flushing. And I certainly think if you're so frustrated and you just want things to work on demand, penile implant surgeries are wonderful and very reliable.
Excellent. I'm bouncing around here. Sorry, the questions are coming in quickly. So bear with me on the bouncing around. We have one question from a friend out there who is wondering about seed implants and focused radiation and what you're seeing with that.
So, there is no perfect treatment for prostate cancer. And I must say, I ache for all of you. I love all of you. And I can't tell you how challenging it is to have these conversations with your doctors and have to make decisions, because they are all challenging decisions. Prostate cancer, there is so much gray. There is no, you must do this or you must do that. And we don't have crystal balls to know, how your body is going to react to each therapy. And before a prostate cancer treatment, many of you can't even imagine what erectile dysfunction or leakage even looks like, because you never had it before. And it can be so life altering. And really, I do encourage that mental health provider, because this is trauma for everybody. This is trauma on your health and your love life. And it's trauma for you as a human, and really encourage you to seek that out. In terms of radiation therapy, what we tend to see is some guys do fine, right? And but the answer is, whereas surgery, maybe your erections are worse in the beginning and improve over time, with radiation, sometimes they're okay in the beginning, and then over time, it can affect the tissues and create worsening erections. But that being said, people also can be older. And remember, 70% of 70-year-olds have erectile dysfunction. So if you're wondering, all of your friends have erectile dysfunction too, you just don't talk about it. You don't talk about it over Zoom calls, except this one. You don't talk about it, with your girlfriends and your guy friends, and it just doesn't come up, right? But everybody, every household is really suffering from this. Listen, I'm in Washington, D.C. I've got patients from Fox News and CNN, right? Everyone has erectile dysfunction, regardless of your political affiliations. And so it's important to know that you are not alone, but that by not talking about it, we just hide in the shadows and think we are alone.
Right. Yeah, that's exactly right. There's no blanket treatment plan for prostate cancer and for any of the issues that we're all facing. So I'm glad that you mentioned that. We have a question from a power couple wondering about just general foods to eat to help with libido.
What's a power couple?
Well, I don't know, but I think we're going to find out.
General foods to eat. Listen, what's good for your heart is good for your penis. And so the data really shows that we have a fair amount of data on Mediterranean diet being both good for male and female sexual function. In terms of that magic food that gets you in the mood, I mean, that might be ice cream for many people, or, it's going to be different for everybody.
Okay. And we've heard a lot about that. And there are some, Dr. Moyed spoke yesterday, and he hit a great deal on what's heart healthy is both vaccine healthy and prostate cancer healthy. So that was a great talk that we can send our attendees to. There's a question, can you actually get an orgasm when using the pump or an implant?
Yeah, I love that question. So when you put a penile implant in, it doesn't do anything to your skin on the outside. So you still feel everything that you felt before. If you can have an orgasm, you still have your orgasm. If you ejaculate, so if you're someone who had radiation therapy and you are still able to ejaculate after penile implant surgery, you should still be able to ejaculate. Now, if you've had surgery, you don't make ejaculate anymore. So you would not have, they wouldn't give it back to you. You would still have that missing. But what the penile implant does is it just replaces the muscle within the penis. And instead of that muscle, it's now these tubes of that fill with fluid. And so it is like a balloon inside the penis that you pump it up when you want the erection and you deflate it when you don't want the erection. So sensation is the same, orgasm should be the same, ejaculate, if you have it, should still be the same. So what you're missing is that internal engorgement, sort of that lengthening, that girthing that you get. That is very difficult to replace with the penile implant. And so you have to work with, I recommend if you are going to get an implant, work with someone who cares very much about this, who knows what they're doing. And there's a wonderful group of providers with the Sexual Medicine Society of North America. They have Find a Provider, and you can find someone in your area who is very, very good.
Great, thanks. We have about 7 minutes and we have several questions remaining, so we're going to do our best to get to each of them. So we have another question about basically just which treatments are you seeing patients come to you having had and having the most sexual problems?
It's a great question. That is a patient who's trying to decide what treatment option they want to go through. And it is so individual. And first of all, I want to say I'm impressed that there aren't people you're either preventing me from seeing all the people yelling in horror of what a terrible talk, or the people seem interested in this. I think the answer is all treatments have potential for side effects. And it is not a one size fits all. Gosh, if it were a one size fits all, we wouldn't need this amazing organization helping to advocate for patients who have, prostate cancer. So the answer is, it depends on your age. It depends on your underlying medical problems. It depends on, I see tons of guys who are not prostate cancer survivors who have terrible erections or terrible pelvic pain or terrible orgasm issues. And so I've seen patients who've had surgery who have better orgasms after surgery than before. And so it's not always a bad thing. I've seen patients post-surgery who get fine erections. I've seen patients post-radiation who maintain fine erections, and maybe there's something else bothering them. And so it is, unfortunately, that's not an easy answer. You're not going to get me on that one.
Fair enough. Okay. We have a question about massaging the prostate. One, is it possible? And two, is it helpful in decreasing the size or in anything else?
So there are a couple of interesting data points out there. There was a paper that came out that the increase in masturbation or the increase in number of orgasms can decrease the incidence of prostate cancer. That made a lot of press for a while. The prostate, which, as you all know from a digital rectal exam, is achieved through the rectum if you want to touch it or feel it. And it has a lot of nerve endings around it, and it can be extremely pleasurable for men to orgasm sort of from behind, from their prostate. And so there are many devices out there that can cause a vibration. Certainly a prostate massage is something people have been doing for a long time of men who have inflammation or tight pelvic floor muscles. So again, anytime you have a pelvic pain component, I really encourage you to seek a physical therapist, because they can work on those muscles to release the tension. Some of us feel our painful muscles up here in our shoulders, but women and men have tons of muscles in their pelvic floors, right? And their pelvis is lined by muscle, and we can all hold tension in different places in our pelvis. And so these physical therapists can work, not only help you stop leaking urine, but they can really alleviate a lot of pain symptoms as well.
Great. We have a question back to the Viagra and Cialis. Can those be used together, or does it need to be one or the other?
I recommend one or the other. The only place that I typically will recommend combining them is if you take a low dose Cialis every day, like a 5 milligram, sort of very low dose to keep in your system. And then right before your desired erection, you take either a 100 milligram of Viagra or a 20 milligram of Cialis, right? So you're sort of doubling it up, that low daily dose versus the on-demand dose. And so that's where I recommend where you can kind of mix and match a little bit, but I don't recommend combining medications. Certainly I don't think it will kill you. I don't think it's going to end you up in the hospital, but I do think the side effects will be increased, and we don't have many studies showing efficacy and improvement in the erections.
Okay. Is there any recommendation for something that men can do before a surgery to help after the surgery?
Yeah, so I definitely think something that we have patients do often is get them into a physical therapist before a surgery or before radiation to learn about your core, learn about your Kegel muscle, learn about how to help with leakage, and learn about your body a little bit. Gosh, I wish everyone saw me before they had treatment, because I can help be their quality of life coach, and I do that for many patients, right? If they're having androgen deprivation therapy, I'm there with them every step of the way to say, okay, how do we make intimacy happen, even though you don't feel very interested, after surgery, before surgery. And so we're hoping to do a research project on this very topic, is what if we get guys coming in to do either a group visit or individual visit before their treatment, and find out then after their treatment, are their sexual satisfaction and their quality of life better if they knew what was going to happen, and if they were prepared with a toolbox of how to live their life the best possible way. And so I believe physical therapy is probably the highest yield thing you can do before treatment.
Great, thank you. Well, we have a lot of kudos for Dr. Rubin, 10 stars, thank you. Really appreciate this talk. I think just one final question and then we'll wrap it up for the night in our last presentation of the evening. But you, which I think is so helpful, you put so many of those search engines up so people can find therapists in their area and physical therapists in their area. And we know that you're a sexual health specialist, but how can people find more of you if they're not in and around the DC area? Is there a good place to get started in finding another Dr. Rubin?
Yeah, there can be only one Dr. Rubin, but
Obviously.
no, I have so many friends and so many colleagues all over the country. So the Sexual Medicine Society of North America, or the SMSNA, SMSNA, there's a new website, smsna.org. And it is a society of all sexual medicine providers. And really, you can find a provider and find someone in your area. Many of the urology practices have someone who has an interest in men's health, an interest in sexual function. The key is to find a doctor who cares. It might not be the same doctor who removed your prostate, right? If you're removing 100 prostates a month, you don't always have the time to truly care about. I wish every doctor had time. We all know medicine is broken, and we all wish we had more time with our doctors, but seek it out. Seek someone who's going to take more time with you. Seek out someone who truly cares. This is the world of telemedicine. You can go across lines now and see someone who can really give you good advice and say, listen, because I think a lot of doctors will offer medicine and injections and vacuum pumps, but they don't spend the time getting to know the patient in front of them to even see if that's worthwhile. And that's the key, because if I talk to a guy where I know under no circumstances is he going to stick a needle, somewhere, it's a non-starter. We have to figure out what works for him and his partner, or just him if he doesn't have a partner, because he is like no other human. And so I really want to put that out there. And the last thing, that you are so important. Your pleasure, your quality of life matters. You are like no other human, and you deserve that care, that compassion, and that sort of biopsychosocial approach. And if you don't get it from your one prostate cancer surgeon, find somebody else, because there are people like myself who truly, truly want to help you live the best life possible.
Yeah, absolutely. I couldn't agree more. And if you get nothing from this presentation, I hope you get the confidence to say something, have conversations with your treatment team, have conversations with your partners, and with the people that care about you, so that you don't feel like you're alone in this.
I love that. The team approach is everything for this.
Yeah, absolutely. Well, thank you so much, Dr. Rubin. For more information, more topics, we have 3 more days of programming. So please keep joining us on our app, on our website, zerocancer.org. And with that, good night to everyone. Thank you for being here. Thank you so much, Dr. Rubin. We can't thank you enough again for this awesome presentation.
Thanks for having me.
Thank you. Good night.